Hello, hello, good evening, good afternoon, good morning to everyone, wherever you are joining us from. My name is Gabriela Fernando, and I am an assistant professor of global health at Monash University in Indonesia. It is my absolute pleasure and honor to be the moderator for today's session, which will be on climate change and health equity. So this session also marks the final gathering in the South and Southeast Asia Climate and Health Responders course. Now, as we know, South and Southeast Asia is home to over 2 billion people and represents one of the most climate vulnerable regions in the world. As we've learned over the last sessions, from rising sea level threats across coastal cities to extreme heat, air pollution, flooding, and vector-borne disease outbreaks, the impacts of climate change are already being felt across our region. These environmental shocks intersect with deeply rooted social, economic, and political inequalities, further widening existing health disparities. Health equity in the context of climate change means ensuring that all communities, especially the most vulnerable and marginalized, whether it may be women and children, informal workers, indigenous communities and populations, and rural populations, have the capacity, resources, and the ability to adapt, respond, and to thrive. The region is rich in cultural, linguistic, and geographic diversity, demanding contextually specific, locally led, and inclusive approaches to climate and health interventions. South and Southeast Asia also have a wealth of local knowledge, community resilience, and innovation that can be harnessed for transformative climate action. So, as we conclude this course today, it is vital to recognize that advancing health equity in the face of climate change is not just a public health goal. So, with that being said, the objectives of this course are as follows. It is to enhance the knowledge, confidence, and the communication abilities of current and future health professionals concerning the climate crisis, to improve population care and public health practice, as well as to serve as credible advocates within their institutions, communities, and professional domains. It is to equip interested current health professionals with the knowledge, skills needed to educate their institution's own learners so that health effects of climate change and emergency preparedness can be incorporated more easily into pre- and post-licensure training across the globe. And finally, to build and strengthen an agile and informed community around climate and health education, advocacy, and policy for health professionals with strong mentorship and expert support. Now, as you have joined us over the last 10 or so weeks, you saw that we started these modules with the first module being about climate change for health professionals, and then moving on to extreme weather events and covering climate-impacted health issues, whether it ranged from infectious diseases to vector-borne and zoonotic diseases to food and water scarcity and mental health, to then looking at building health systems and what it means to be sustainable in healthcare delivery. And just last week, we learned more about advancing climate justice through effective climate change communications, engagement, and advocacy. So as I mentioned before, today is the final module on climate change and health equity, and today's session's learning objectives are as follows. It is to identify social and environmental determinants of health that make individuals and communities more vulnerable to climate-related health threats, whether these may be elderly populations, women and children, socioeconomically disadvantaged populations, homeless people, Indigenous and First Nations communities, refugees, immunocompromised patients, patients with chronic medical conditions and/or NCDs. We'll also describe the concepts of climate justice and environmental justice. It is also looking at demonstrating how to supplement theories of collective and transgenerational ethics and ethical obligations to the natural world with more individual oriented, present-oriented, and human-centered frameworks of climate and health ethics, justice, and traditional knowledge. And last but least, to understand the role of health professionals in climate and health communication. So before we go into today's session's content, I wanted to give some quick reminders and logistical information. The session will run for around 90 minutes, which will include two of our expert presenters, one who will present the expert lecture, as well as an expert who will present our case studies. We will also have some time for a Q&A session where you can enter your questions for presenters in the Q&A chat box. And the session will be recorded, and the video recordings, the slide decks, and resources will be made available to you through the course website. Your attendance will be automatically recorded during this live Zoom sessions, and we ask that you please join us using your personal Zoom links. And it's a quick note that YouTube views will not be counted towards attendance. In regards to certification of your participation, as we've mentioned earlier, for participants who attend at least 7 out of the 11 live Zoom sessions and pass the final examination with a score of 70% and over, you will be awarded with a certificate of participation from the GCCHE. A quick note about the final exam: it must be completed using the same email address used to attend these live Zoom sessions. The exam will be sent out today via email and by WhatsApp and will close on Sunday, the 20th of July at 12 midnight India Standard Time. The exam is formatted to be around 25 multiple choice questions as well as true and false questions, and the examination will take place in one sitting. Okay, so with that out of the way, it is my absolute pleasure and joy to introduce you to our two expert presenters. Our expert lecture will be delivered by Professor Tintin Su, and our case study will be presented by Dr. Sumbal Javed. And so without further ado, please allow me to warmly introduce you to Professor Tintin Su. Professor Su is Professor of Global Health at the School of Medicine and Health Sciences. She is the Director of Southeast Asia's Community Observatory, Health and Demographic Surveillance System, and the Director of the Regional Hub for Asia, Climate Change and Health at Monash University, Malaysia. Professor Su is a public health physician and global health researcher. She is also a founding member and former vice president of the Asia Health Literacy Association and former executive board of the International Health Literacy Association. She is an internationally recognized leader in health literacy, having received multiple awards. And Professor Su integrates health literacy into her work on climate and health interventions. Professor Su will drive the Regional Hub's research agenda on promoting climate literacy, community empowerment and responses, and climate and health system strengthening, with a particular focus on climate vulnerable groups. She is also an honorary professor at universities in Malaysia as well as in the UK. So, Professor Su, it is my absolute pleasure to give you the floor. I'll allow you to share your slides now.
Thank you so much, Gabrielle, for a very nice introduction. So let me share my screen. Can you see my slides?
Perfect.
But it's not yet in the slideshow mode, right? Okay,
No.
so I think now is the slideshow mode. Okay. Great. Well, good morning, good afternoon, and then also good evenings, for all participants around the globe, but I guess particularly from South and Southeast Asia region. So my lecture is the last lecture, so I am sure a lot of informations are already shared by my previous lecturer. So I will skip the learning objective. And then before I start my presentation, I want to acknowledge several colleagues for sharing, some slides. Professor Raina Sawabon from Hyderabad University Institute of Global Health. I took a couple of his slides on the concept, and Dr. Chanji Ki and then Mr. Hussein Rizal from the Regional Hub of Asia Climate Change and Health, and Mr. Aaron from Institute of Global Health, University College London, particularly some slides on gender and health equity, and Dr. Hamima Tunisia Juha. So the content of my presentation will be health equity, social determinants of health and climate justice. It's a kind of a background definition. Then I will go to power and voice of climate vulnerable population. How are we going to take power and voice of climate vulnerable populations in the intervention, whether we are taking their power and voice, in the current scenario. I'm going to give a little bit more information on gender, climate change, and health equity. And then finally, last but not the least, action for climate change, health, and inequities. So what is health equity? The absence of avoidable, unfair, or remedial differences in health among groups either defined by socioeconomic, demographic, or geographic factors, or by other dimensions of inequality. Why does it matter? Health is a fundamental human right, and health equity is achieved when everyone can attain their full potential for health and well-being. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerless and lack of access to good jobs with fair pay, quality education and housing, safe environment, and healthcare. So health equality monitoring is also integral to its attainment. So this is slides showing individual determinants of health, how it displays important role for people who attain optimal health situation. So this clearly mentions 50% can be traced by your zip code. So that means our postcode. Socioeconomic factors such as education, job status, family and social support, income, community safety, and then physical environment. So those are 50% of determinants, for your health. And the health behaviors, tobacco use, diet, exercise, alcohol use, sexual activities. So the healthcare play only 20% of a role for people who attain optimal health status. This is a little bit sad, for us as a healthcare profession. But this is also not, clear cut, 40, 10, 30%, because the health behavior and socioeconomic factors, play hand in hand, together. So you might want to ask the questions, what about the structural determinants of health? What about the policy? What about the politics? What about the climate change? How those play important role? Then let me share a slides on, this is a comprehensive slides from WHO, social determinants of the health, conceptual framework. You can see those are the structural factors, the social determinants and political context, which include governance, macroeconomic policies, social policies, labor market, public policies, culture and societal value, and then the social economic positions of the individuals. So it includes gender, ethnicity, education, occupation, incomes. And then there are some intermediate determinants because all that structural determinants and individual socioeconomic positions play an important role for behavior, biological factors, psychological factors, and so on and so forth, and working environments, and then our health systems, so that, impact equity in health and well-being. And again, this social determinants of health, framework, it was in 2010, still not include about, climate change and health. So last but not the least, I managed to find, World Report on Social Determinants of Health Equity. So that was a release, if I'm not mistaken, either March or May 2025. So those, economic systems, social infrastructures, structural discrimination, so on and so forth, and then individual socioeconomic positions are more or less the same. But, it includes, meta trends on climate change and digitalization. So those are the important, determinants, so social determinants of health and health equity. Last lecture already covered about, climate change justice. So I'm going to refresh a little bit of your memory. So climate change is unjust because of intergenerational justice. So the way we act is, or the way we behave, I mean, our lifestyles, our policies, everything, will play an important role for the next generation. And then air pollutions, and then temperature, global warming, it's a totally different with, my grandfather age, my father age, and then now what we are suffering. And of course, perpetrator and victims, poor versus rich, and then gender issue in socioeconomic inequality, and then climate change and health equity, and different climate vulnerability. So what is a climate vulnerability? This is a degree to which people or communities are at the risk of experiencing negative impact of climate change. Climate vulnerable groups are older adults, marginalized groups, disability, and then it depends on their locations, people who live in a climate, people who disaster-prone locations, they are more vulnerable. So, and I want to go a second part of my lectures, the power and voice of a climate vulnerable population. So this is showing rich, poor versus rich, exposure risks and evidence. I think this affects is also everyone know. So those are the countries which more this contributes, to greenhouse gas emissions, But once you look at, estimated mortality of the impacts, it's more on low-income countries, from the global south. And what about the evidence, which kind of evidence, we can find, if we want to look for climate change and health, is there any way we can make a solutions? So most of the publications, based on the global north, particularly North America, Europe, and Australia, rather than, Africa and Southeast Asia. So we established a regional hub for Asia climate change and health. So we try to find the research solution or research priority of the climate vulnerable population in Southeast and Southeast Asia. So we did the regional stakeholder surveys, in early, this year, 2025. And then this is a kind of, showing, but I'm not going to go through details. We're trying to look, search for who are the climate change and health, champions or stakeholders in the region. So we did the literature search, and then we also did the active, grant search to identify the stakeholders. And then we sent the questionnaires, and then we invited, of course, Malaysia response high, but you can see several countries, from the Southeast and Southeast Asia response, our survey. So we also sent an invitation to the lecturers and then case presenter from this course, and then they also responded, so the response was quite good. Finally, we managed to get 94 response, from academia, governments, NGO, and industry. So this is a vulnerable population that, our Southeast Asia should take, immediate actions, infant and children, older adults, and then, outdoor workers. So you can see that, infant adults, older adults, are more on biological vulnerability, but indigenous people, outdoor workers, and farmers, construction workers, those are more on socioeconomic positions. They are socioeconomic positions, they are vulnerable. Of course, women, it's biological vulnerability, and then also their gender inequality. So I want to pick up, one of the issues, as examples, because climate change is a really huge area of research, So I'm going to take, one examples on the heat and health. So heat reduce, what capacity. So it depends on how much job exertion, required, so temperature is higher and then, getting higher and then what capacity is getting reduced. And you can see this is a predictions, of the world globe temperature. And then, most of the countries, from global south, will be suffering, increase climate change and health. So many low and middle income countries are estimated to lose 2 to 8% of GDP in 2030. So there are a lot of, health effect on heat, heat stroke, dehydration, kidney damage, renal stone, cognitive malfunction, mental health, so on and so forth, particularly people, the outdoor workers. And we also did the scoping reviews, we want to know, are there any solutions, community-based solutions in the regions? So we did the scoping reviews, and then we identified, finally 54 studies on climate vulnerable populations in Southeast and Southeast Asia. And then we want to know observational and interventional evidence because the observational studies are mainly highlighting the mechanisms and then also a kind of discovery research. Interventional research are solutions, it's a solution-based research, applying research. So how many solution-based research, climate interventional research in our region is doing? It's certainly more than 95% of studies are observational study design. Of course, the majority are air pollutions and heat, but mostly those are the observational study. So once we talk about the interventional studies, and if we want to get the voices of the vulnerable populations, co-designing is a very important approach. But nowadays, co-designing is a very popular words, people are using, but we have to understand, the researchers are really doing co-designing or just, consultations, to the community. Co-designing, need to do very proper and rigorous, approach, exploratory phases, developmental phases. First, we need to engage with the vulnerable populations. We have to plan it, we have to learn, community experience and identify area of the improvement. And then we developed, we need to transform idea, gather from community into the interventions. And then we need to use, iterative approach. So that means, consultation is just go and consult. Okay, this is the interventions, we are going to do. Community say yes, no, and then you should improve, but this depends on research teams, whether they improve or not. But the co-design, we have to improve. We have to take, opinions from the community seriously, and then we make the decisions, together with the community. So one of our heat interventions, heat literacy co-designing, heat literacy toolkits, finally, eventually, we did the user testing, we have a different language, Malay, Tamil, Mandarin, so, and then we try to include, all ethnic groups in Malaysia. So eventually it took, 1.5 years, to do a proper co-designing. So not only South and Southeast Asia regions, this phenomenon is globally. So this is a paper we recently published in the Lancet Planetary Health, our systematic review. So you can see this is globally the number of paper on heat and health, say heat and climate change, heat effect on health, is increasing, significantly. But community-based, heat adaptation studies are very few. This is a global phenomenon. And then available studies are mostly in the global north, USA, Canada, Italy, Australia, Japan, so only 2 studies, identified, from our regions, and then also low and middle income country, of course, the middle income countries like China and Pakistan. So that show our regions, we really need to do a lot of interventional studies, solutions, and taking into consideration of, power and voice of the climate vulnerable population. I'm going to touch a little bit of gender, climate change, and health equity, my third component of the lecture. So I'm not going to read, the whole slides. You can go and read, these slides. So the gender is different with the sex. Sex is a biological factor. So gender, it's more on social cultural factors. So why we have a health risks, about the climate change? There is a climate exposure, so location relative to the hazards, and then people vulnerability, and then, also the climate related, hazards. So overlappings of the climate-related hazards, exposures and vulnerability, this is where we can see the health risks. For example, older adults, older populations, they have a vulnerability, but they are not exposed, to the temperatures. And then during daytimes, they can have air-conditioned rooms, and then, they have a proper hydration, their chronic conditions are also properly treated, then, they have less, likely to have a health risks. Of course, there are a lot of, gender impact of climate change on health, air pollutions and air quality, so toxicity of work environments, for firefighters, who are predominantly men in many societies. So it has been exacerbated, escalating, climate change. So once we talk about the gender, not only we are talking about the female, so we are talking about, both male and female. It comes to food security. Women are more frequently affected in the nutritional deficiency and anemia because of the biological vulnerability, and then also our gender role. And then heat, women experience heat-related illness, because they are the most of the men's most of the outdoor workers are male. But anyhow, some literature also report, higher temperature-related, all-cause mortality in women, compared to men. It might be one of the reasons because, women live longer. And once, someone live longer, they also have a lot of, chronic conditions. So maybe once you look at, temperature-related all-cause mortality, women might be higher than male. So this is also possible, justification. In terms of infectious disease, male are more commonly at risk of leptospirosis due to activities such as animal caretaking, farming, fishing, and then playing, water sports. Women in the rural area often care for backyard chickens and ducks, making them more susceptible to avian influenza. Violence, increased gender violence towards women and girls, after extreme climate events. So is planetary health, programming, gender responsive? So 37% of nonprofit organizations, which are active in the planetary health, make no mention about gender in describing, their planetary health activities. And 24%, have planetary health activity that recognize the structural cause of, gender inequality. 38% have a planetary health activity that responds to the specific needs of the woman and girl alone. So you can see there are differences of the planetary health programs, taking care about the gender inequality. So there are importance of, sex disaggregated data from United Nations, but I'm not going to go through these slides. Once we look at the visibility of the gender in data, so across 99 nonprofit organizations active in planetary health, only 18%, has some sex disaggregated, data, and then, 92%, there is no data found. So now it's the last part of my presentation. It's a framework for the actions. I like this slide, or I like, this picture, because this is, very simple. So one size does not fit for all. So we have to do a different level of interventions, to tackle climate change and health inequality. So there are spectrums of, health interventions, healthcare professionals, can be done. And particularly the communication skills, nowadays a lot of, there is also systematic review. I didn't put it in my references. So there is one what's getting popular, climate sensitive health counseling. So that means, healthcare professionals make the counseling. So it's not only the health counseling. We need to include, climate and health co-benefit. For example, physical activity. Once you want to improve, physical activities, Then, cycling. Cycling can improve physical activities. So physical activities are the best medicine for all kind of diseases, particularly non-communicable diseases. But using cycling, this is also climate, friendly solution. So once we talk about consult about lifestyles, you're not only talking about the health risks and health benefits, we also need to talk about the climate benefits, the co-benefit that we call it, climate sensitive health counseling, and even, dietary recommendations, to eat, more veggie. Maybe some patients say, oh, we don't go frequently to market, and then, sometimes, we run out of, fruit and veg in our house. Then, promoting, gardening, own gardening, community gardening. This is also good benefit, for health, and then also green environments, preventing, air pollution, so on and so forth. That we call it, climate sensitive health counseling. So that our healthcare professional play a very important role in the climate sensitive health counseling. So to do such kind of climate sensitive health counseling, to do climate advocacy, our healthcare professionals, should be climate smart or climate literate, healthcare professionals. So we really need to work a lot on this area. But of course, there are spectrum of climate actions, climate change mitigation, adaptations, the policies, governance, rules and regulations, transport systems, living conditions, so on and so forth. This is a kind of intervention. And then we also need to empower, collaborate, advocate, to address social and structural inequality. So that means, one size does not fit for all. One intervention cannot tackle everything. We have to do a lot of, parallel interventions, to take care of health, to take care climate change, and then also to take care socioeconomic inequality. Of course, I like this slide, because this is, very clear and very clean. But of course, this is a little bit, busy slide. So I think this is more or less similar, but there are a lot of actions included, which kind of things we should, consider we should take care. So here, I think this is really important role, community capacity building and engagement. Community should be climate smart. Community should be climate resilient. Community should be climate literate so that they can be a part of actions to solve climate change and health inequality. Of course, partnership with different sectors, NGOs, governments, community, research organization, advocacy, communications are very important. Although I mentioned, we really need, a lot of, solution-based research. Surveillance is also very important, to monitor how much, improvement we make, particularly how much, inequality, how much inequality can be reduced, for all sorts of, policies, interventions, so on and so forth. So those are my take-home message. Take-home message one, the root cause of climate change and the upstream drivers of health inequities are often the same. The health risks and impact of the climate change are not equally or fairly distributed across people and communities. Some are climate vulnerable population because of their socioeconomic positions and gender issue or location. Climate change exacerbates existing health and social inequality. So gender, social and economic positions again. Intervention that upstreams shared systemic costs can most effectively address, both climate change and health inequality. But the power and voice of climate vulnerable populations are very important. Power imbalance have allowed the creation and perpetuation of unhealthy living conditions associated with climate inequality and then climate vulnerability. So the lack of power and voice also constrains the ability of community to respond to climate change impacts and contribute local knowledge to climate solution. So building community resilience, I want to stress again, it is required to transform system in ways that foster health and reduce greenhouse gas emission. So those are my references. Thank you so much for participating in this course and listening my talk. So Gabrielle, over to you.
Thank you so much, Professor Su, for highlighting those key elements of health equity. And I think you really nicely showed to us how climate change further exacerbates and contributes to these existing inequities. You help us to see how social, political, economic, and these environmental determinants are shaped by circumstances of climate change, and how, unfortunately, in turn, these affect some of the most marginalized and vulnerable populations. So thank you so very much, Professor Su, for your expert lecture. Now we turn to Dr. Sumbal Javed. Allow me to introduce Dr. Javed. She is a visiting research assistant professor at the Global Health Department Health Services Academy in Pakistan and affiliated with the University of Hong Kong. Dr. Javed brings expertise in global health and climate governance, health policy financing, and humanitarian and multilateral diplomacy. She was a philanthropic fellow at the Institute of Philanthropy, Hong Kong. As a seasoned anticipatory strategist, she has led initiatives addressing dual-use risks in health security and designed financing mechanisms to future-proof vulnerable health systems against climate shocks. Her work with multilateral platforms reflects her ability to mobilize coalitions to preempt crises. Previously, she worked for the National Institute of Health. She has produced several evidence-based policy recommendations on global governance, including financial architecture, climate, and just transitions for forums such as the G20, the COP, and also G7. Dr. Javed, the floor is yours.
Thank you. Thank you. Greetings, everyone. I hope you're all doing well. Thank you, Professor Tintin, for highlighting equity in health and climate nexus, particularly the focus on disaggregated data collection. And thank you, Dr. Gabriela, for the kind introduction. And my slides are there. So without further ado, let's begin. Next slide, please. All right. So welcome to our final session. Over the past week, we've explored how climate change intersects with health across South and Southeast Asia. So let's focus on case studies from Pakistan, a microcosm of climate injustice and resilience. We'll first examine Pakistan as a macro case study, revealing why it epitomizes global climate inequity. And then we'll zoom into maternal health interventions during the 2022 floods, where community-led solutions turned vulnerability into strength. This dual lens, a very national and hyper-local, equips us to drive equitable climate health actions in our own context. So next slide, please. All right, so learning objectives, I think everyone else before me and Professor Tintin has gone through them. So we'll just move over to the next slide, please. All right. So Pakistan, the paradigm of climate injustice in South Asia, a macro case study of systematic inequity, global failures, and health impacts. So Pakistan presents a critical case study for examining climate equity. While contributing minimally to global emissions, it experiences disproportionate climate impact. The 2022 floods exemplify this imbalance, affecting 1 in 7 Pakistanis and damaging over 1,000 health facilities. Understanding this paradox, it really helps us frame equitable climate responses that prioritize the most affected regions. I will talk about the most affected regions in a while. So the health professionals, as health professionals, we must recognize that Pakistan's crisis isn't anomalous. It's a diagnostic template for climate inequity worldwide. Yeah, so I think there are some statistics here, as we can see. Next slide, please. Thank you. So some statistics here for you. Emissions contribution is 0.3% globally. Vulnerability rank is 8th most climate vulnerable country globally according to the Global Climate Risk Index 2025. Human toll is in 2022 floods submerged 1/3 of the country. It displaced 8 million people. It killed over 1,700 people and caused 30 billion in damages. Health systems collapsed, 13% of health facilities destroyed, triggering outbreaks. Malaria surged 5 times to 2.6 billion cases. Cholera infected 2,000 plus due to contaminated water. 44% of children in flood zones face acute malnutrition. So according to at the time, Pakistan's climate minister, he said that this isn't a climate crisis, it's a crisis of justice. We pay for emissions we didn't create. Another issue is melting glaciers, which is a consequence of emissions worldwide. They now endanger communities. The very vulnerable communities. For health equity, we must address these root causes of emission and not just symptoms, because climate disease, as Professor Tin has mentioned earlier, and in many sessions before, it has been that climate disasters do exacerbate gender inequality. And when floods hit women, they lose access to healthcare while they are bearing increased care burdens. In relief camps. In relief camps, inadequate sanitation exposes them to violence. This isn't incidental. It reveals why equity must center those most marginalized. So gender inequity during peacetime should be worked on, and so that during the crisis time, this is something that does not exacerbate the conditions that we are already in. Next slide, please. So let's look at the structural drivers of vulnerability. I'm going to touch upon the colonial roots of vulnerability. It was very rightly done so in the previous session. And just to take it a step further, treating climate health impacts without understanding the colonial roots is like, like if you're a clinician, you understand prescribing a painkiller for a very systematic disease like cancer or a tumor. We must name the historical diagnosis to treat the present. So when we look at infrastructure, we see that historical and economic context deepen vulnerability. How so? So colonial water management system created long-term flood risks, while contemporary financial constraints limit adaptation capacity. This intersection demonstrates why climate solutions require both technical intervention and addressing systematic barriers. For health professionals, I think there was a question earlier. I was looking at the Q&A. So for health professionals, I think this means for advocating for context-sensitive infrastructure investment. In addition to all our other activities, this must also be taken into consideration. So yeah, I mean, just very quickly going through these bullet points, like colonial era irrigation prioritizes export crops. Yeah. Overall flood control and post-independence infrastructure gaps are post-1947. So the independence was in 1947. So post-1947 infrastructure gaps that concentrated risk in poor regions. There's a debt constraints limiting adaptation and global climate finance inequities. Again, I think there was a question earlier I was looking at in finance inequity. So there we are. These are some of the systematic issues that we face. Right. So next slide, please. So this isn't exactly a multilateral framework. This is more of a progress and gaps when we look at some of the financing mechanisms. So you can see here on the table. I'm sorry, I have very basic tables because I'm not very good at making tables. So I only know how to make very basic diagrams and very basic tables. So please bear with me. I'm going to explain this to you. Loss and damage fund, we are aware of these funding mechanisms, loss and damage fund, green climate fund, adaptation finance. So what was promised, what was delivered, and the held allocation that is missing. While the national commitment climate determinants are not part of our session, but that's definitely something to be looked into. I think just a minute. Yeah. So 500 billion for loss and damage delivered, health allocation, green climate finance, 10 billion, 2.8 billion delivered, and 12% was only health allocated. So health is constantly receiving reduced funding from these climate funds. I mean, repeatedly we have addressed this issue. There have been resolutions at the World Health Assembly. There's been recognition at the COP, and yet the health allocation budget is so little from the total climate budget. And we all know how much the climate impacts health, as we've again gone through all these sessions very wonderfully by all the other speakers have been explained very well. And then adaptation finance is this much, 40 billion per year, 23 billion delivered, and only 9% health allocated to health. So while COP agreements do represent important progress, implementation gaps do persist. I think we living in the regions which we have seen floodings and other disasters, we very well can have observational skills also, and we can see that implementation gaps do persist. Only 9% of adaptation finance reaches health projects, despite climate's profound health implications. This underscores the need for health professionals to engage in policy process. Again, health professionals can, engaging in policy processes and ensuring funds address clinical priorities like disease surveillance and heat resilient facilities. Next slide, please. Again, I think this area has been covered wonderfully in previous sessions. And again, today, Professor Tintin has covered this wonderfully. But just like very quickly, as we can see, ethical framework, the core principles, procedural justice, which means inclusive decision-making. So procedural justice requires involving vulnerable communities in planning. I think, again, I did notice a question in Q&A earlier. So when we talk about justice, we talk about ethical frameworks, and we try to have an equitable response. This means that involving vulnerable communities in planning, people with lived experiences, so such as consulting women on maternal health needs during floods. Distributive justice means prioritizing clinics in high-risk areas. These principles, transform abstract ethics into practical clinical guidelines for health professionals, especially for health professionals navigating climate challenges. So again, of course, there was again previously some talk of intergenerational ethics, future-focused planning, and corrective justice, historical responsibility that we have covered previously through over colonial lenses and other things. Next slide, please. When I was preparing the presentation, I thought this is going to be a pretty short presentation, but it seems like I do have a lot of description here that I want to make sure that I address these things. But if I'm running out of time, please do let me know. So this picture very quickly, as you can see that this is, we're moving on to the part 2 now of the presentation. So flood responses, case studies, solution and action, immediate response, maternal health protection. So what do we see here? We see here, this is a Kotai Health Center in the district of Dia Khan of Khyber Pakhtunkhwa province, which was impacted by the 2022 floods. The Kotai Health Center was near the bus stop, easily accessible for all who stopped there due to ease of access in normal conditions. The center was well attended, and the lady health visitors, as well as the doctors and midwives. So the center on average catered to over 300 childbirths every month. So during the flooding, the area around Zafarabad Bridge was closed and conditions were hazardous to travel. But Kotai was the only center functional in this area. Also notably, during the floods, UNFP provided support to 8 health centers in Dia Khan and the districts of KP province through deployment of midwives, lady health workers, and other staff provision of newborn baby kits, clean delivery kits, and other equipments to ensure that women in flood-affected area receive uninterrupted basic emergency obstetric and newborn care services. Next slide, please. So Health Heroes, Support of Sisterhood in Climate Crisis. This is not the title. This is just me writing this because when you hear their stories and when you meet people who are truly doing heroic work. So very quickly, these are the community midwives, and community midwives are often traveling long distance on foot in emergencies, enduring fatigue and dehydration to reach their destinations. Similarly, facility-based midwives sometimes must quickly return after attending one case to attend to another waiting at their facility. Despite the challenges, they exert maximum effort to reach each patient in need. Sometimes midwives continue attending to cases consecutively for more than 24 hours without adequate rest, demonstrating their unwavering commitment to providing essential healthcare services. A testimony from a lady health visitor whose name here is Mahnur. She worked at the Kotai Health Center, which was previously shown in the district of Dia Khan of Khyber Pakhtunkhwa province, which was impacted by the 2020 floods. So for a midwife, she says it's not a job, it is a calling. The best part of being the midwife working in these harsh conditions is a feeling of being part of something bigger. It is a real understanding of being part of sisterhood, respect each other without any boundaries. Next slide, please. So here we can see this is Sephora. She was in the flood during the 2022 floods prone area. So she's holding her child, Samira, as she waits to be seen by a midwife who've set up a pop-up clinic in the tent encampment she's been living in since floods washed away her home. The clinic is run by Neha Mankani. It's a midwife who leads the Mama Baby Fund, and this picture is courtesy of Dia Hadid from NPR. All right, next slide, please. And here you can see the midwife Mankani. As previously mentioned, she is checking the fetal heartbeat of a pregnant woman. As she works, other women waiting to be seen cluster around the makeshift clinic fly screen windows. So this is a makeshift camp, again, courtesy of Dia Hadid, NPR. Next slide, please. So as previously seen, these are very real conditions and very real urgent needs that needs to be addressed, that needs to be taken into context and when planning any response, specifically during the peacetime, so that when they're in case of any humanitarian crisis, we have the system in place an equitable system in place to address the challenges which are being caused by the climate change. So here, very quickly, I'm just going to go through this. I think we have so during the floods, community midwives became Pakistan's frontline maternal health responders. These locally recruited women, they were trained through 18 months national program. They navigated submerged villages using boats and donkeys to reach the stranded pregnant women. Their deep community roots enabled trust building in conservative regions where male health workers they face access barriers. So these are the women from the community trained, and they were then deployed. And specifically in conservative societies where the male health workers, they face some barriers. So portable delivery kits were critical in preventing infections. Each $5 UNICEF kit contained items ensuring 6 cleans. As the 6 cleans are clean hands, perineum, delivery surface, cord cutting, and cord tying, reducing neonatal sepsis by 76%. In flood camps, women-only spaces were established, and 40% of 40+ temporary shelters with privacy screens, breastfeeding areas, and trauma counseling. So these women-only spaces addressed cultural needs and trauma. They were established in school buildings and tents. They provided privacy for deliveries and counseling. It was a model also adopted by Somalia's humanitarian programs. Next slide, please. So here again is my wonderful table. It's so simple and easy to understand because that's the only way I know. So here is some key organizations and coordination mechanisms. Government of Pakistan and the role and the impact that these organizations had. So they deployed the coordinated response leveraged Pakistan's existing CMW network, which was established in 2006. So during floods, the government fast-tracked deployment through its National Maternal Emergency Protocol. So yes, there is a National Maternal Emergency Protocol, while of course, notably again, UNICEF, the expedited kit deliveries using pre-positioned warehouse, cutting usual delivery time from 6 weeks to 72 hours. So these are some of the organizations that are critical. So that's UNICEF, WHO, and hence Pakistan is an NGO. And so some of the lessons from Sierra Leone's maternal crisis informed training, CMWs learned flood-specific skills, delivering on elevated surface, identifying waterborne sepsis symptoms, and using rainwater for sterilization. Next slide, yeah, thank you. So infrastructure and capacity building. Of course, then we would talk about innovations like mobile clinics, telemedicine kits, community ambulances, psychological first aid training. Infrastructure adaptation turned constraints into opportunities. When roads flooded, CMWs used fishing boats as mobile clinics, storing kits in waterproof containers. Local mechanics modified tractors with stretcher mounts, creating ambulances that transported 120 high-risk mothers. Capacity building focused on sustainability. CMWs received psychological first aid training from the Spotlight Initiative, enabling them to conduct gender-based violence risk assessments while distributing hygiene kits. All right, next slide, please. We're almost at the end. So some of the key outcomes are trust-based care. We again have a testimony. I'm sure most of us are very, very aware of especially in remote regions, building trust takes time. So having people from the community, trained people from the community, really ensures that enabling these community members during peacetime ensures that during the crisis, we are then able to deploy them, and if, of course, provide additional support if needed. So success emerged from cultural adaptation. So the CMWs, the midwives, like Sakina, integrated traditional practices, allowing amulets during births while ensuring sterile techniques. This respect for local custom increased community acceptance. A critical lesson is kits alone aren't enough. Effective distribution required engaging male elders through mosques. Future responses must budget for CMW's mental health support. I believe Professor Tintin did touch upon mental health of the healthcare workers. So I think this is also another important point for us, is that during the future responses, we must have budget and we must have other additional resources available for these community midwives for maternal health support, mental health support, because as they exhibit secondary trauma from repeated emergency deliveries. Yep. So again, like just final thing, persistent challenges, post-flood retention dropped to 40% due to unpaid stipends. So only 15% of kids reached ultra-remote communities. Next slide, please. All right. So these are some of the transferable best practices, Pakistan model that this was deployed, the CMW protocols. The core principles for success train local women, ensuring cultural access, pre-position supplies, and integrate mental health. As climate disasters escalate, empowering midwives, its survival equity. 87% of maternal services can be delivered by midwives when trained to WHO standards, making them the most cost-effective climate health investment. All right, like community ambulances, Bangladesh floating health clinics serving cyclone-affected areas. So these are some of the transferable best practices. Women-led spaces, kits and training. Next slide, please. So we're at the end of our presentation. I mean, this is just dozens of women wait outside a pop-up clinic run by midwives in a tent encampment for families who were made homeless by Pakistan's unprecedented summer monsoon rains. This again is back from 2022 that caused widespread flooding, courtesy of Dia Hadid and PR. Yep, that's it from me.
Thank you so very much, Dr. Sumbal, for the case studies from Pakistan. I think it was so wonderful that you particularly showcase the relationship or the intersection of climate change in women that was also discussed by Professor Tintin Su earlier. And it really goes to show the impactful work that's been done in Pakistan and, of course, in other parts of the region as well when it comes to maternal health. And thank you for highlighting the important work that our community maternal health heroes have been doing in building resilience in local communities. Thank you so much. So for the remainder of the time, let's take the opportunity to turn into our panel and have a Q&A session. I'll allow you, Dr. Sumbal, to take a quick break, but in the meantime, we've got a few questions here, and I'll start with perhaps Professor Su. We've got a question from Hajira Makbul, and the question for you, Professor Su, is how can frameworks incorporate intersectional approaches that consider overlapping identities, for example, gender, race, disability, income, to ensure equitable health outcomes in the face of climate change?
Well, I think it sounds like, I need to repeat the slides, a lot of, action. So, well, I think this is a very tricky questions and then tricky issues, So I think I have to tell my previous words, one size, does not fit for all. So the best thing is to do a kind of, situation analysis, what people really need, what is the existing, policies and strategies, sometimes, there are a lot of, facilities, existing strategies, people can tap in, but, we don't know. And then, not only healthcare professionals, also the intersectoral collaboration and cooperations are really important, for example, disaster-prone area, disaster management, so I think once we design, one of the programs or interventions, we need to take into consideration of not to exclude, anyone, and particularly vulnerable populations, how to make things gender inclusive, how to make, our programs, to reach to the vulnerable populations, low-income populations. I think it's really need to talk to the community, so that's a co-design approach to include, voices and the opinions of the vulnerable populations, to be included, in the interventions or programs. I think it's also monitoring is really important, so that, we know whether we can reach vulnerable population that, we want to reach. If not, how are we going to improve, delivery of healthcare services and the delivery of the programs? And definitely, I think the healthcare workers play a very important role. So maybe I can talk about a little bit about, regional hub for Asia climate change and health. We plan to do climate literate, healthcare workforce. We want to promote, climate literacy among the healthcare workers. Once we did the expert panel discussions, and the expert panel mentions, not only healthcare workers, but also all volunteers, who involved in the disaster management, like NGOs, community leaders, and voluntary health workers, like Pakistan's. They should be involving, not only they are climate literate, they also need to play advocacy roles, to the community. So I believe in the community empowerment, community resilience, so I think the intersectoral collaboration and cooperations are really important, to do programs and interventions, for the climate vulnerable populations. Hopefully I answered the question.
Absolutely. Thank you. Thank you. And I think you raise a really great point, and throughout the presentations, both of them, we highlight the role that health professionals play. Dr. Sumbal, if I can turn to you, I wanted to ask a question, and that's a question that's actually posted here by a participant, Meruba Shamin. The question is, what role should health professionals play in advancing health equity and advocating for climate justice? Are their current climate policies adequately incorporating equity and health concerns? And how can community members influence local and/or national policies related to health and climate?
Thank you for that wonderful question. Just a very quick answer for that. Sorry, just a Yeah, so sorry. Yeah, so I think most important thing, as we discussed previously during Professor Tintin's seminar, also was data collection. I would really emphasize on data collection. There's very limited data collection, and methodology is extremely important. We must emphasize on having a correct methodology when collecting data, especially from the remote places. Now, these remote places that some of the case presentation we've done is very remote, very far-flung areas, hard to reach, conservative, cultural custom barriers. So the idea is to look into how to overcome these barriers and get to these people and talk to these people and correct the data correctly, and then come back, publish it, talk to your local authorities, health authorities, risk disaster management authorities, and so on and so forth, and then globally, take it globally.
Fantastic. I love the fact that you raised the point about data. There is actually a question that's been asked about the role of data as well. And Professor Su, if I can turn to you because you wonderfully showcase one of the projects that you're currently working on, which is around co-design. So, speaking of co-design and how you bring key stakeholders together, one of the questions that's been asked is, what is the durational aspect of the co-design phase? How do you include key stakeholders? How do you identify these key stakeholders within certain communities? And what are some effective tools to identify community stakeholders and also the tools used in creating these frameworks?
Okay, thank you so much. Of course, I think this is a really a very important question. So maybe I will go back to the studies, we conducted. So Gabrielle introduced me nicely. I am director of the Southeast Asia Community Observatory. This is a health and demographic surveillance site. We run in Sangaman district in Malaysia for 13 years. So during that 13 years, we already build a trust, between, community and their research teams, and the university. And then Dr. Javed also clearly mentions, trust. Trust is a very important, so researchers need to trust to the community and the community need to trust to the researcher. And then once we talk about the co-design approach, some of the researchers are not so sure how that, community opinions, can, be incorporated, our designs, whether it reduce the robustness of, our methodology. So, of course, once you work with the community and then once, the trust is built, between the community and researchers, things can be done, But for me, I think I am very fortunate situation that, we have already built the trust of the community. But of course, if you really want to go to the community that you didn't work before, then I think the best thing is to talk to the community and then try to identify, the government officials, NGOs, who are active and working, in the community. And then, after that, you may need to go to the community leaders, community elders, So, I mean, talking to the community, exploring, and then also document analysis, sometimes, a lot of literatures are not published. A lot of, great literatures, reports, so such kind of things, it takes time, to do the document analysis, review of the literatures, so on and so forth, and then talk to the community. Then, we need to do some, qualitative approach, even, the community can identify the stakeholders. So sometimes, we did the workshops, stakeholder mapping workshop. So then, community come up, and then, some of the stakeholders, and then we do the stakeholder mapping workshop. So the name of the stakeholder mapping methods, just tip of my tongue, but, you can look for it, So we look at the interest and power. So dimensions, so there are 4 quadrants, some, stakeholders, high interest, high power. High power means, high influential. And then some, stakeholders, they have a high influential, high power, but they have no interest. And then, some stakeholders, they have an interest, they have no power. And then, some, stakeholders, no power and no interest. So then, we need to start working with, the stakeholders who are high interest, high power, or people who has a high power, but, no interest. Then, we need to engage. And then, we need to bring, those people, to be part of stakeholders. So I think I did such kind of framework. It's very simple and then practical framework. So some of the research, we also do the stakeholder mapping workshops, that workshops, we can identify, who are the important stakeholders. And then, we can map it, high power, high interest, low power, low interest, so on and so forth, I think this is a very practical and then it's a very useful tools we use.
Thank you so much. And speaking about regional collaborations, Professor Su, I want to turn to Dr. Sumbal here. I think the case study that you provide actually has a lot of best practice examples that could be transferred to other parts of the region, if not globally. So a question that I wanted to ask from you, Dr. Sumbal, is what are the potentials for regional collaboration and also for cross-border knowledge exchange?
Right. I'm just going to add on to what Professor Tintin said about collaboration. I think we do have an issue with working in isolation at all levels, I'm afraid. Someone has to say it. And usually that's me in the room. So at individual levels, at institutional levels, in governance, we see there's so much fragmentation and people working in isolation and over, it's climate change. It's not happening above your house. It's not happening above your street. It's not just your country. It's global. It's impacting societies and communities at large. If it is not you today, there is a very, very high chance that it's going to be you tomorrow. So isolation is not the answer at any level. So we do need to put aside our very set kind of mindsets if they are there that, oh, we have a certain task and we need to complete it and then move on. We have to learn to merge our tasks together. So that's merging your disciplines, right? Now you've got to merge climate with health. This is what's happening with the financing, as I very briefly discussed, that we're not merging the financing in climate and health, whereas the impacts, it's very interconnected and very palpable. So yeah, I mean, that's very important. So advocating and collaborating at all levels is important. I mean, we just need to have very relaxed discussions. I think, like Dr. Tintin mentioned about the stakeholders mapping, a lot of times when we meet for stakeholders mapping, there is a lack of understanding, which is perfectly fine because there are many new initiatives going on, and we may not be aware of all the initiatives in place. So the idea is the icebreaker. I think ice breaking, we have to learn new techniques for ice breaking, and we just have to take it as a discussion. We're all here for the same reason, and we want to address these challenges together. So I think ice breaking is very important, and how you do that, you have to be creative. And regional collaboration, of course, is extremely important. And there is a lot of discussion when it comes to funding on regional collaboration, South for South collaboration. I'm sure we've heard this word popping up here and there. And of course, then so I think in terms of some of like I have seen all the sessions before, and a lot of these sessions that they mentioned, some of the things that they're using are very much transferable and have been used. So, for example, if you look at the regional cooperation, of course, it amplifies impact. For instance, India's heat action plan, I think a few sessions ago, someone spoke about the tin roof, those tins coating. So some of those have been used in Pakistan, Karachi, in urban centers, while Bangladesh shared flood predictions methodologies. So such knowledge exchange accelerates effective solution transfer and builds collective resilience. It shows us how shared climate challenges can foster, like I said, collaboration across traditional boundaries. So, I mean, from Bangladesh and Pakistan, they have similar flood early warning sharing and some regional training on climate sensitive diseases and joint research on agriculture adaptation, because this region there's a very agriculture a region in India, Pakistan, Bangladesh, some other countries as well. So I think, again, sharing of lessons learned and collaborations across border and regional collaboration. Yeah.
Fantastic. And I'm just conscious of time, but I thought I've got a really great question that I'm probably going to pop to the both of you. I'll start with Professor Su. The question is, how can health equity be integrated into climate adaptation financing? We've been talking a bit about financing, especially in Dr. Sumbal's presentation, into climate adaptation financing to ensure justice for countries, particularly in the global south, that is most affected by climate-related health risks.
I think I should refer this questions to Dr. Javed because she talked more on climate financing. So hopefully you
Yeah.
can take the questions. Thank you.
Dr. Sumbal?
So I think the first thing is, again, we need to have assessments, right? We need to do research. We need to do data collection. It's very basic. We need to have the information. So a lot of times when you want to work on, say, a policy brief, right? You want to have recommendations, but your recommendation is going to come from facts on the ground. So someone's got to be doing that data collection. Someone's got to be telling us. So there's a lot of segregation when it comes to data, and there is not a lot of correct methodology that is used. And again, there is not collaboration between people who work in finance, for instance, finance ministry, the people who work in climate change ministry, people who work in the health ministry. So these people and these institutions, I would say institutions. So all institutions, whether that's academic or government, state or non-state, NGOs, everyone who's working together. I think the most important, and a lot of times there's great literature, like Professor Tintin mentioned a lot. So how do you plan financing? How do you plan how much investment has to go in? I think in my presentation, I mentioned that there's an underinvestment in vulnerable region. Now, common sense would dictate these are vulnerable region, high risk region, invest, invest, invest. However, we do not see that. We see underinvestment. And why is that? Again, there is, I think my presentation was not exactly quintessential because not all areas that have hit by flood, except these examples, are not almost always that remote. So I did share a case study which is quite remote area. Maybe there are many accessibility barriers, whether that's physical or otherwise, but not all areas are that hard to reach. So from there, getting those people there, if they're high risk and not as remote as this area, accessible, those still need to be highlighted, right? Whether again, that's through multiple coordination and across stakeholders, or through literature, because we're from academic institutes, so we'll talk about that. That's one of the reasons for underinvestment.
Yeah, absolutely. Well, thank you so very much. I feel like this topic about climate change and health equity, we could just go on and on because there's just, there's so much and so many aspects that we have to talk about. Unfortunately, we are over time, and I need to do the closing. And, for those who are finishing and closing for the day, wishing you all very well. But thank you so very much to Dr. Sumbal and Professor Su. Thank you so much for your presence, for your expertise, for sharing your expertise and your knowledge. And thank you all so much to all our participants for joining us today. Before we close, I would like to invite the Director of GCCHE, Dr. Cecilia Sorensen, to please give us the closing remarks. Thank you.
Thank you so much. I'm so delighted to be here with you today. My name is Cecilia Sorensen, and I'm the Director of the Global Consortium on Climate and Health Education. As we mark the conclusion of the South and Southeast Asia Climate and Health Responders course, on behalf of the GCCHE, I would like to express our profound gratitude and pride in what we've accomplished together. Over these weeks, we've addressed critical regional health challenges, including extreme heat, vector-borne disease, food and water insecurity, air pollution, mental health, health equity, and resilient health systems. We've been privileged to hear from leaders across South and Southeast Asia, including clinicians, policymakers, researchers, and frontline responders who have shared both scientific insights as well as practical, clinically grounded, and culturally grounded interventions. Huge thanks here to our faculty who have been presented at this course, as well as to all our participants across the region. Your active engagement through your discussions, through your questions, the case presentations, the reflections have made this course, not just a series of lectures, but really a vibrant community of practice. We've connected with each other in ways that we never would have otherwise. And together, I believe that we've deepened our self-efficacy in climate and health communication, as well as built this new network across South and Southeast Asia, where we can together advocate for resilient, climate-ready health systems. This course would not have been made possible without our incredible working group and all the partners who contributed to that, including WHO CIRO, Ashoka University, CDC New Delhi, Monash Indonesia, and so many others. We've been working for months to bring this course together, and a huge thanks to all of you for being part of this critical effort. Additionally, I want to give a special thanks to all our faculty whose experience and expertise really elevated every session and ensured that these lectures and conversations were really regionally grounded and meaningful. So as we wrap up, I want to highlight 3 essential calls to action. The first is that we can't stop here. We have to amplify this work. And we urge you to take the knowledge and the frameworks from this course back to your institutions, be that an academic institution, a government institution, or a civil society organization, or your community. Take what you've learned, share this with your colleagues, and integrate them into your work, whatever that is, to educate more health professionals, to educate community members, to educate policymakers. We put these courses on for free in order to ensure that this information is propagated as it is needed to be at this critical time for the health of our planet and the health of humanity. We also urge you to lead with evidence and with equity. So let the data on climate and health outcomes related to heat illness, vector-borne disease, food insecurity, and so on really drive your clinical practice, your health professional practice, your public health practice, and health systems planning. We hope that you take the learnings from this and critically integrate them into whatever professional practice you embark on. I think there's lessons here for everyone. And last but not least, we're here around the concept of community and around the idea that together we can tackle this great challenge of climate and health. Over the past 11 weeks, we've built more than knowledge. We've built a network, and I hope that we can continue to collaborate, mentoring each other, sharing resources. And with that, I'd like to invite you to consider joining the Global Consortium on Climate and Health Education. It's free to join. You can join as an individual. You can join as an academic institution. You can also join as a civil society organization. And as you join us, we invite you to other types of courses. We can tap you into other networks, including our working groups. And also you can join our expert speaker repository so we can call on you as we continue to run courses throughout the world. We also have access to a huge number of resources that hopefully will aid you in your journey. The Global Consortium on Climate and Health Education was started in 2015 at the Paris Climate Accords, and the vision is to ensure that all health professionals throughout the world will have the knowledge and skills to prevent and respond to climate and health impacts wherever they occur. So our mission does not end with awareness, it really begins with action. So may you go forward as advocates, as educators, as clinicians, as public health professionals, and as leaders who protect health by responding to the call of action. So thank you all so much, and I hope you enjoy the rest of your day.